Hi, welcome to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory. I am a reproductive endocrinology and infertility specialist, and I am board certified in both Canada and in the US. So we reach out to a broad audience and like to help everybody. We try and make your fertility journey better every time by presenting new data, new information, giving you the best of what's available so that we can make your journey as effective for you as possible and hopefully as cost effective for you as possible, because I hate the fact that people spend so much on these cycles. So welcome to the show. If you're new to us, normally we have about 15 or 20 minutes where we present a topic and we go over everything. And at the end of that, we kind of sign off on whether there is good evidence or not good evidence for a new technique or a new procedure or any data or evidence that we need in terms of making sure that your journey is as successful as possible. And then we go into the live questions tonight because there is really nothing exciting out. We are going to just go straight into live questions. So hopefully if you guys have some good questions, you can start asking now. And it's usually a very busy night when we go straight into questions, because a lot of people want to jump right in and get their questions answered. Make sure if you're on YouTube, you hit that subscribe button. We're always looking for more subscribers. And on Instagram, follow us. Same thing on Facebook. So with no further ado, my trusty friend Tarek from Ibrahim Strategies Group is here. He will remain faceless for now, although we keep getting requests to see him. And we are ready to go. And congratulations to Tarek on his 15th anniversary. Way to go, dude. Well done. Yeah, so that's it. I hope you all had a good weekend. If you're in Canada, a happy long weekend. I hope it was enjoyable. I did go surfing. It was freezing, but it was fun. So that's it. Do we already have some questions? Yeah? All right, cool. Fire away.
How do you diagnose Hashimoto's?
So essentially, it's a combination of what's happening to your thyroid and then the presence of thyroid antibodies. So there are multiple features that go into it, but your endocrinologist should easily be able to do that for you.
Hi, Dr. V. I've had the miscarriage panel done. Chromosome test and tested for anti-phospholipid blood clotting panel.
Yeah.
Protein SC.
Yeah.
And all have come back normal.
Okay.
I'm trying to figure out what other tests I can get done to RO anything that
rule out
anything that could possibly cause more miscarriages.
So we would do the Fertility testing to look for your immune system and see if that's impacting things. And then we would also do the Fertility infection testing. Your partner needs sperm DNA fragmentation testing, and he needs his genetic testing done if he hasn't done that already. You need a very detailed history to make sure it's not related to smoking, drinking, drug use, anything like that in you or your partner. You need your iron checked and your vitamin D checked. Those are all important. I think those are the main ones we would look at typically. Swabs and a saline infusion sonohystogram to look at the inside of your uterus to make sure that the inside of your uterus is completely normal. So all of those things would be pretty important for you to do.
I'm doing a mini IVF, low dose IVF cycle in July.
Sure.
And I'm considering asking my doctor to add HGH. I hear mixed reviews on HGH, either to prime with or as part of stims. Do you ever use HGH?
Yeah, so we do use HGH. We've done a couple of presentations actually on the show on HGH. So to the best of everybody's knowledge right now, as of the current evidence, it looks like HGH can help you make more eggs. It can make you make more mature eggs, and it may make you make more embryos, but it does not actually increase live birth. However, we almost always exclusively use it when you're doing a cycle where you're trying to stim to make the most number of eggs and the most number of embryos. So to combine HGH with just a mini stim doesn't make a lot of sense, because you're targeting a lower number of eggs, and that's not really where we would place HGH use, where you're really trying to target the maximum number of mature eggs and embryos. So I wouldn't use those two together. But if you're doing a full stim, it would be reasonable to consider.
Collecting of content here.
I figured that. We're going to need 2 cameras soon.
It's coming to that.
Yeah.
Yes. Hello, Dr. VNT. Oh, this is a great question.
VNT.
When will you open a clinic in the U.S.?
So we're working on it. Probably in about 8 months to a year, we're going to look at that possibility just across the border. So our numbers have been so phenomenal. Our growth has been so incredible that that's definitely something we want to explore. So yeah, we're definitely aiming in that direction. It's just a matter of having enough time to spend to do it. So, but yeah, we have had that plan in the works for some time, and I'm almost there. There's a couple of things I need to see happen, and then we'll do that.
So a comment that you received. Hello, doc. So my gynae suggested to me to get it done one day after my period, the saline infusion. Okay, so that's what they
Okay, sure.
after the ovulation.
Sure.
I am scheduled tomorrow, but I'm ovulating now. Should I wait until my next period, or can I book after ovulation? Hold on.
You cannot book after ovulation, and if you're already ovulating, it's first of all, it's a very early ovulation, which would not be normal. And secondly, if you're ovulating already, I would recommend that you not do it, because when they flush your tubes, you're actually just going to push the egg out into your pelvis, and you can't recapture it. So if you've ovulated, you cannot do a saline infusion sonohysterogram or a hysterosalpingogram. You're essentially pushing the egg and or the embryo right out of the tube, and that's not a good idea.
I've had my vitamin D checked. Iron was kind of low, so I started iron pills. My vitamin D is great. I don't smoke or drink, and my husband did the genetic testing based off of my results, which one thing showed up, but he wasn't a carrier.
So you're talking about comprehensive chromosome screening, and I'm talking about karyotype to look at your chromosomes. So comprehensive carrier screening is when you look for individual little genes, cystic fibrosis, SMA, PEX disorders, muscular dystrophy, so on and so forth. But what I'm talking about is karyotyping, which is your chromosomal makeup. Do you have a reciprocal translocation? Do you have a balanced translocation? Is there mosaicism present? Same thing for your partner. So those are 2 very different tests, and they're not covered by comprehensive carrier screening, CCS. So definitely take a look at that. I'm glad to hear your vitamin D was good. That's really important. Make sure you get your partner's sperm DNA fragmentation done. And then, like I said, the fertility testing, so their immune testing and their menstrual infection testing, both of those can be quite important.
People are finding out you're answering questions right away.
They all come like crazy, right? I know.
That one's like whispered, hey, he's doing it right now.
Yeah.
I saw your video from a couple years ago on ovarian PRP. At that time, it didn't seem to increase live birth rates. Is that still the case?
There's only one study on PRP. It is not a controlled trial. They demonstrated an 8 to 11% live birth rate. So, I mean, it's pretty mediocre. It's only usable in women who have had diminished ovarian reserve, but who are younger. So if you're like 43, 44, you're going to do PRP because you want to rejuvenate your ovaries, it's not going to work. So don't waste your money, save your money. That's useless. But for patients that are young, they're like 32, 33, 34, and they've had a diminishment in their ovarian reserve, it can work, although it's not amazing, but it does give you some chance, possibly above and beyond what's normal. We really don't know. So we're probably going to start doing it very soon. We were just talking about it on Friday. So yes, it's up and coming. It will be pricey, unfortunately, because it itself is pricey, and then we got to put you to sleep, and then we got to get in there with a needle and inject, and it's got to be all sterile. So it's going to be involving quite a bit.
Should I feel bad as a man for trying to conceive with my wife without changing my lifestyle and no vitamins and no exercise? Could this have a big impact on our future child? Please help.
Oh, wow. We've never had anyone ask that question before. That's a fantastic question. Listen, I would never tell anyone to feel bad, so I'm certainly not going to start with you. Do we wish that all partners, male, female, whatever gender you identify with, would be supportive and contributing in a positive fashion? Yes, of course we do. If your lifestyle is a good lifestyle, then you're already doing all the right things. If your lifestyle is smoking, drinking, drug use, you're looking at roughly about an 80% decrease in success, and you're looking at a massive increase in miscarriage. So I'm not telling you to feel bad, but you do need to sit down and process that and judge for yourself what's most important to me. You know, do I need this to function on a daily basis, or do I need my child more or my wife to be happy more, or whatever the case is. So you have to make a decision that's right for you. We never kind of force people to do anything, but certainly making proper lifestyle choices is important for your own health, and it does contribute to the health and well-being of your pregnancy and your child. Can you make differences with exercise? Certainly if your weight is high, it does have a very negative impact on sperm as a male. So yes, it can impact things. And same thing for women. It has a huge impact on eggs and development. On our website, under the resources tab, we have a whole section just on how weight impacts fertility. So go there, download the long booklet, like the full booklet, instead of just the brochure. And it's got all the information you could ever want. So yes, I mean, lifestyle choices are critical. We pretty much on every single show tell people that they need to make good choices. I'm not going to tell you to feel bad, but I'm going to encourage you to make good choices for sure. Why don't the ladies out there tell us how they feel? Why don't you message us, ladies, and tell us if you feel like your husband should feel bad? Help this guy out and let him know what you're thinking, so that he knows what the purveying view is.
First medicated cycle, 2.5 milligram letrozole.
Okay.
Day 14, scan today showed 2 follicles,
Okay.
10 and 12 millimeters. Can they still grow, or is this cycle a bust?
That's a bit slow, but they can still grow. I mean, it's day 14. Normally, we don't like to go on oral meds past day 17, 18, because then the egg quality is not very good. So you are getting really close, but you're close. So, I mean, I would ride it out and see if they grow enough. You still have a chance. You probably need a higher dose next time, or injectable medications added into the mix. So it's possible.
Hi, Doc and T.
And T. Doc and T.
Yeah, it's a serious question here. Low mosaic,
Yeah.
1 inconclusive,
Yeah.
2 untested embryos, 4 40-year-olds, 4 40-year-olds.
Okay.
No other complications. Would you do 2 fresh transfers, or which order would you pick for a first transfer? I would like 2+ babies.
So you're 40 plus, you have 1 mosaic, 2 untested, and 1 abnormal?
Low mosaic, 1 inconclusive, and 2
Oh,
untested.
1 inconclusive.
Mm.
So, I mean, I would put them in 1 or 2 at a time. It is highly unlikely, unfortunately, that you will be able to achieve 2 pregnancies from that. We will be fortunate if the low-level mosaic sticks and takes. You have about a 50-50 chance that it will be normal. The chances of it actually becoming a live birth are highly dependent on not just the genetics, but the quality of the sperm, the quality of the eggs, you, and so on. So within the framework of your center's chances of getting you pregnant, there's a 50-50 chance that mosaic embryo will result in a normal pregnancy. So I guess if your question is, should you put in 1 or 2 at a time, at 40 with no knowledge about the embryos other than the mosaic, I don't think a lot of people would argue that it's not unreasonable to put in 2 at a time. Like, I think it's totally fair and reasonable to put 2 in at a time. So I would be comfortable with that. Is it going to achieve a pregnancy? I really don't know. I certainly hope so. Our prayers are with you. But is it going to achieve 2? That's probably a bit of a stretch. It would be difficult to achieve 2 pregnancies at 40 from 2 untested embryos and 1 mosaic and 1 unknown. So I would kind of hedge your bets and do 2 at a time and see how things go. Keep in mind that does significantly increase your risk of having twins if they are 2 normal embryos. And twins are complicated, and that can actually lead to multiple complications in the pregnancy, both for you, for your offspring, and then those complications can last a lifetime for the offspring, especially if they come early. And there's social impact because it's a very high divorce rate. So you need to feel comfortable with those risks before you go ahead. This is something you need to discuss in tremendous detail with both your obstetrician or a high-risk specialist if you're in the US, in addition to your RE. So make sure everybody's on the same page before you make any final decisions, and make sure you make an informed decision based on knowing all of the facts, not just me saying it to you. You have to make a decision that's right for you after you fully understand the risks and benefits as explained to you by your doctor.
We have had a total of 4 IUIs from last year to current.
Okay.
Original was male factor, which is now corrected.
Okay.
Just had all my hormones rechecked. Not sure what my AMH is, as still waiting to get back from your clinic.
Oh, okay.
I have checked out to be okay both times and yet to ever be pregnant.
Sure.
We want to know the next steps you suggest from here. 36 years and husband 37.
So 36 with 4 failed IUIs, you're really at the point where you decide, do I do a maximum of 2 more IUI because we won't do more than 6, or do you just go straight to IVF? The alternative, and I don't know who you are, and I can't talk about that anyways at the moment because we're all live, but the alternative, if we haven't done it already, is to explore surgery to see if surgery is an option for you. So if surgery is an option for you, that's a great choice. The problem right now is that it takes forever to get people in for surgery. So I would recommend you kind of look at things and make a decision that's right for you, but it may take a long time to get into surgery. So it's either 2 more IUI, IVF, or going in to see if there's something else wrong, or additional other tests that are available, right? Like the immune testing, the infection testing, to rule out those things. We don't typically do those unless you're doing IVF, but you can. So if you don't want to jump right into the expense of IVF, you just want more answers, there are some ways to get you more answers.
Hi, Dr. V. No tea.
No tea.
No tea. But this seems like a new viewer, so
Okay.
I let them.
You're going to let it slide?
Yeah.
That's really nice of you.
My husband's sperm morphology dropped from 2% to 0 within 1 year.
Oh,
No major changes in lifestyle.
okay.
No alcohol. No smoking. Any idea about how this happened? Any tips to improve?
Low vitamins, excessive weight, low exercise, stress, exposures, chemicals, plastics, any kind of solvents, cleaners, industrial stuff. All of those can be a problem. Infrequent ejaculation can be a problem. Those would be excessive heat, excessive tightness. Those would do it too. And then scrotal problems. So if you have a varicocele, which is like too many veins around the testicle, like a varicose vein around the testicle, that can also do this. So yeah, there's a bunch of different possibilities, but you need thorough investigations to figure that all out. Usually, if morphology is the only problem, if you ejaculate frequently, keep the testicles cold, take the fertility vitamins for men, you can restore some morphology.
Hi, Dr. V.
Hello?
I have Hashimoto's.
Okay.
However, my thyroid levels are fine. I'm taking ivoxafarine.
Levothyroxine.
Yeah, levothyroxine.
Yeah.
Should I be worried about miscarriage?
If you have high levels of antibodies, yes, unfortunately. So selenium and inositol, and depending on what your thyroid level is, they may need to overdrive you a little bit to get the thyroid levels down. So these are questions you have to review with either your RE if they're knowledgeable, or with your endocrinologist, because there's definitely data demonstrating that the thyroid antibodies negatively impact your chances of success and significantly impact your chances of miscarriage.
Jumping on to Instagram.
All right.
Um,
I think we're a commercial for Diet Pepsi. I shouldn't have done that.
Yeah. Hi, Dr. V and T. Oh, wait. Hi, Dr. V and T. Dr. V. Not that.
Okay.
So hi for me, but this message is for you.
Okay.
Thank you for today's news of 2 PGT normal embryos at the age of 42.
You're welcome.
We still can't believe it. Thank you for being with us every step of the way.
You are very welcome. I know who this person is because I just spoke to you today. Congratulations. So excited for you guys. We were really happy that Cooper Genomics told us we have, if not the highest, one of the highest rates of genetically normal embryos in the country and a very high success rate in terms of biopsying. So we were very, very pleased with that information. Big round of applause for the lab. So yeah, my amazing team in there are doing a very good job, and obviously we know how to make good eggs and embryos. So yeah, it's worked out really, really well, and you did great. So thanks for hanging in there. You were a miracle. Yeah, very, very well done.
Hi, Dr. and T.
You know, as we go through the show, you progressively put more emphasis on the ante every show. All right, fire away.
How can I be few months older and my AMH go from 18 to 23? Does my follicles more eggs retrieved means lower quality for a 40-year-old?
So if your AMH is going up, that's just lab error because it can't go up. So that's just going to be lab error mostly, unless you have significant weight changes or you were suppressed for some reason before. As far as your age is concerned, I mean, with increasing age, your AMH will go down. But if you can make enough follicles, your age is a very significant factor, but it's something we can work around because you can make lots of follicles, which means lots of embryos, hopefully, which then means more chances that 1 or 2 or 3 or as many as possible are normal. So that's the key. You need healthy eggs and then healthy, strong embryos. And they need to be genetically normal embryos. So the more you make, the more the chance that you'll find those embryos.
Can you say why the preference for fertility testing over Emma and Alice? Why are these types of microbiome tests not as widely available in the U.S.?
I don't know why they're not available in the U.S. It's a simple test, so it should be available in the U.S., but I don't know why it isn't available in the U.S. As far as the Emma and Alice testing is concerned, I had a negative impression of iGenomics for a variety of reasons. First of all, the ERA test doesn't work. They know it doesn't work, but they're still marketing it. So I find that just dishonest. The second problem is that when they came to us to present Emma and Alice, they said, if there's bacteria in the vagina, it doesn't match what's in the uterus. I said, okay. So they said, you need to do these tests to figure out what's in the uterus. And then based on that, you can direct treatment. And I said, okay, what's the treatment? And they said, well, you give antibiotics. Okay, that makes sense. And then you give probiotics. And I said, well, how do you give the antibiotic or the probiotics? And they said, vaginally. And I said, didn't you guys just tell me that what's in the vagina doesn't reflect what's in the uterus? They said, yeah. And I said, then why are you thinking if you put something in the vagina, it's going to get in the uterus? Now we do it, and we do it with our fertility patients, and it does work, but they didn't have an answer, and so I just kind of found the whole thing awkward. So I don't use them. There's nothing wrong with doing meta-analysis. Fertility testing is a bit more sophisticated, and iGenomics doesn't do the immunological testing, and a lot of our patients are combining the immune testing with the infection testing. I think it's actually about the same price. So I don't think price is a major factor, but it's a very reasonable thing to do. I prefer fertility. I have a very good relationship with them, and I can reach the guy anytime I want, and so it's been good so far.
I have stage 4 endometriosis.
Okay, sorry.
On my right over. Oh, sorry. I have stage 4 endometriosis with an endometrioma on my right ovary.
Okay.
I also have a hydrosalpinx with my right fallopian tube.
Okay.
And have surgery set to remove both.
Okay.
Would you recommend IVF before surgery to retrieve eggs before surgery?
It depends on the size of your endometrioma and whether it's going to interfere with your egg retrieval. Typically, what we try to do is do retrievals ahead of time, make the embryos, then operate, then suppress you, then do your embryo transfer. And the rationale is, if you do your surgery now and then you go through an IVF cycle, no matter what you do, you're getting higher than normal levels of estrogen. That estrogen is going to fuel your endometriosis and make the endo increase. If the endo increases after you've done surgery, you just kind of did the surgery for no reason. So what I believe makes the most sense is do your IVF as long as you can get around the endometrioma. You can't always. So if it's big, you have to have the surgery first. Then do your IVF first, then do your surgery, then get suppressed because you need the suppression to shut down all the endo, and then try for your embryo transfer.
What does immune testing involve?
It's a blood test, and they are checking you for cytokine levels, complement levels, natural killer cell activity, DQ alpha with fertility. I just got a full DQ alpha match today, which probably explains why that couple's having problems. So yeah, there's a bunch of different tests that we do. And then they'll tell you what the treatment is for it as well, so they can kind of guide you for what treatments are best.
Main factor.
Male factor or
no,
main? Main factor.
Main factor for poor egg quality. Solutions.
Oh. I can't say that there's one factor for poor egg quality. Habits, age, genetics, vitamin intake, diet, your body mass index, stress levels, exposures. I mean, there's a million different things that go into it. The number one determinant of your egg quality is your age, but that's not to say that there aren't women that are young and have terrible eggs. There's lots of them. So it does happen, and we don't know why that is the case in those patients.
Surgery for what? Did I miss that? So this was the question.
Surgery to remove your surgery from the IUIs. Surgery to determine if there's something we're missing inside you that is stopping you from being successful. So this question is from our viewer that said she had 4 IUIs before and wanted to know what the next steps were. And so my answer was 2 more IUI, surgery, or IVF. Mm-hmm. So with the surgery, we're looking for endometriosis, adenomyosis, scarring, damage to your fallopian tube, signs of previous infection, something abnormal inside the uterus, cervical stenosis. Like, I kind of have a mental checklist of everything I go through, and that's what we would be looking for.
It's amazing you remembered that question like that.
It was like 2 minutes ago.
That's why you're Dr. Victor. That's the sign. Dr. V, any good news to schedule surgery in the Windsor Clinic?
Yes. So we have 3 separate trials. They're all being planned right now. First week of June, I want to say, is one of them. And then, or second week of June, and Mara and the team is working on the other one. I don't have specific dates yet, and it's still in the works, so don't hold anyone to it, but it should be very, very soon for the hysteroscopy. And I just contacted the company so we can start doing D&Cs here, because I absolutely hate taking our patients to the hospital to do a D&C because it takes forever. I had 3 patients wait 2 days just to get a D&C done. So yeah, that's up and coming, and we'll be able to help people out here.
Hi, Dr. VNT.
VNT.
Exclamation mark.
That's us.
If doing a modified natural FET,
yeah,
should you have an LH surge and transfer 6 days after HCG trigger, or no surge 7 days after HCG?
The timing does not matter. They just did a study recently which shows day 5, day 6, and day 7 are all going to give you basically the same results. So I would probably err more towards 6 or 7, but 6 and 7 don't make a difference. Whether you trigger or not is up to you. the key is to make sure that you know that your progesterone is going to start to spike after you've released the egg. So when you do it with HCG, you kind of know the timing a little bit better. When you do it natural, you just got to make sure you don't miss the ovulation, because if you miss it, you'll get the wrong timing, and if you go too late, it's birth control. So we would probably often trigger if we were worried about that. We don't do the true modified natural. We do letrozole because it's been shown to improve the success rates, and Lord knows our success rates are incredible. So we're using letrozole for everybody. I don't do very many natural cycles, if any.
When can we start testing for pregnancy after an FET if we cannot wait for 2 weeks?
So you can probably test at around 8 days at the earliest, and you might see a positive on blood work. The problem is it can go up initially and then go back down. So we don't like getting people nervous, and that's why we ask you to wait the 2 weeks, because it's more of a sure thing at that point. But yeah, you can test after 8 days with blood work. It may or may not be positive, and then you'd try like kind of every 2 days. But the earliest I've ever seen it is at 8. And that's when it's like, 12 or 20 or something like that. It's like really, really low.
PGT tested said low mosaic and euploid.
Sure.
One doc said this was very promising, but the second doc said because I'm 39, the egg is probably the issue and gave me 5% chance. Also, the report said
what?
Monosomy 14. What is your opinion?
So it's a 50-50 chance with a low-level mosaic. Unfortunately, you have a whole chromosome mosaic, which means you're mosaic for the fact that the whole chromosome is missing. Monosomy, yeah, whole chromosome is missing. So, there's still a very reasonable chance it's going to develop into a perfectly happy, healthy baby. Whoever told you it's 5% has no clue what they're talking about. That's just not consistent with the latest data. So it's a higher chance than that. Now at 39, it is more difficult to get pregnant even with a genetically normal embryo. So that will play a role, but it's not 5%. Yeah, not unless your center has very, very low success rates.
Can you explain in detail what benefits metformin has for PCOS with insulin resistance? I'm on it since December, no weight loss, but I've got one natural period, which is rare for me. Could it help egg quality?
Okay, so if you have PCOS, many women with PCOS, particularly those that carry more weight, have insulin resistance. So that means that their body is not sensitive to the insulin that they are producing. This can eventually lead to diabetes. What does metformin do? It sensitizes your body to your insulin. How does that impact things? In detail, there are insulin-like growth factors, IGF, in and around your ovary, which have a lot to do with hormonal functioning and physiological functioning in your ovary. Insulin itself also plays a role. And then, of course, the whole sugar and glucagon and the homeostasis of your metabolism. Excuse me. So when you're taking metformin, you're reestablishing a normal baseline. And so that can be very, very helpful. Metformin in and of itself doesn't typically make you lose a lot of weight. And if you're trying to lose weight, you must do exercise and you must adhere to a strict dietary habit. So 6 meals a day, breakfast, snack, lunch, snack, dinner, snack. And you need to eat very, very judiciously in terms of calories, maximum around 1,300, 1,500 a day. So this is a very calorie restricted diet. I'm currently trying to lose some weight because I gained weight too many pounds, and it's seriously difficult to calorie restrict. So you need to be on a very calorie restricted diet, and you need to exercise hard. Walking is not exercise, it's a waste of time. You need to be doing HIIT training, HIIT, high intensity interval training. So that combination will get you to where you need to go. In terms of additional factors, yes, it does have a higher percentage of women that are going to start to menstruate on their own and ovulate. But metformin by itself has never been shown to be amazing. Metformin with letrozole or metformin with Clomid synergistically actually makes a significant difference compared to Clomid or letrozole alone in the PCOS group. It will also long-term delay the onset of diabetes. So all of those are good things. There can be some impact long-term on hair growth, acne, those as well. So that's the most in detail answer I think I could give you on short notice, but that's how it works. Was that good?
That was great.
That was great. All right.
That's as detailed as you can get.
Yay me. Yeah.
Curious. Is there any wiggle room for transfer during Ontario funding? I'm 35 years old with 2 failed transfers of a PGT normal embryo. Does it continue somewhere else? Yeah, I live in Windsor and I'm doing funded IVF in TO. Can I do my monitoring at VRC? I did my IUIs at VRC, so I'm already a patient.
You can do your monitoring here if the center you are working with is willing to have a contract with us to pay for us to do the monitoring for them. So yes, it's possible, but the rules and regulations of the funded system require that your center have a contract with us for doing the monitoring. The problem with FETs is that there's absolutely no money to be made in doing the government's funded FET program. Like literally, it's a money loser for everyone doing it. As long as you have more than one embryo, we are losing money when we do more than one transfer. So the problem with it is virtually no center that has the actual funding is willing to pay anybody else to do the monitoring, because the monitoring is actually expensive. I need to pay an ultrasound tech an arm and a leg because they're very expensive. We need to pay for the ultrasound, which is very expensive, space, supplies, time, reception, yada, yada, yada. And then that's just the ultrasound. Then you need all the labs. So I need a lab tech, I need a machine, I need the kit, we need someone to draw the blood, so on and so forth. So when you pile all of that together, it's actually quite costly to do the monitoring. And if they're not willing to pay anything for the monitoring or want to pay very little, no one's going to agree to it. So is it possible? Yes. Have we done it? Yes. You need to contact your center and say, are you guys willing to contract VRC in order to provide these services?
Hey, Dr. V, what doctor do I see for immune testing?
Me. That was easy, yeah. So we can arrange immune testing for you. I've got colleagues that do it as well, but yeah, you're welcome to contact us and we will do that for you. If you want names of somebody else, then I can provide that for you too.
Hey, Dr. V, high NK cells, is there any hope?
Oh yeah, tons. Steroids, Plaquenil, Viagra, GM-CSF, intralipids, subcutaneous IG therapy, lit therapy. I mean, there's a laundry list. Tacrolimus, sirolimus, although those are more the T helper cells. But yeah, there's a ton of stuff that you can do for high NK activity. Intralipids in particular tends to work very, very well. So there's lots of options for you.
Here you go. From Instagram.
Okay.
I am, before that one. Can I exercise as I normally would for IUIs this month?
Oh yeah.
I usually do boot camps and HIIT training, or should I stick to my lower impact activity like yoga?
I mean, I would be fine with you doing it up until the point of the IUI. Once you've done the IUI, I'd probably start taking it a bit easier after that. Nothing too intense. Boot camp's pretty tough, so I wouldn't do that. But kudos to you for doing it. That's a tough workout for sure. Have you done boot camp?
Of course not.
Yeah, you and I do a boot camp every Tuesday on dinner. Yeah, we are religiously eating. Yeah, yeah.
I'm 38 with DOR.
Okay, I'm sorry.
I've done 4 retrievals and 5 transfers.
Wow. Okay.
3 transfers were negative.
Okay.
One was a miscarriage.
I'm sorry.
One chemical. Am I crazy to try another retrieval?
Oh, God. Okay, nobody's crazy. Well, that's not true. I have a few family members that are crazy, but I guess we all do, right? So nobody's crazy, but I would say that the yield is going to be limited if you have DOR and you're 38. So in a situation like that, we would tell you you've got about a 10 to 15% chance per try. There is a study out of Harvard from many years ago which showed that if you do up to 6 cycles of IVF, your cumulative birth rate was 83%. So it's not crazy to try. It's expensive to try, but it's not crazy. So yeah, if you want to continue trying, that's fine. In our program, I feel like if I can't get you pregnant within 3 tries, then it's not likely going to happen just because our success rates are so high. So it's very rare that we let people do more than 3 tries. But, it depends on your center and who you are and your finances and how important this is to you to have your genetics versus donor egg. So no, you're not crazy. You shouldn't feel you're crazy. It might be a good opportunity to seek some discussion with psychological counseling before you do another case, just because, or another cycle, just because you want to make sure that you know where your line in the sand is. IVF can be addictive, and I'm very fiercely protective of my patients. I won't let you spend money if I don't feel that it's going to work. So we tend to be very cautious with those patients, and we want you to at least have a sounding board to bounce these, things that you're feeling off of. Like, what if I don't try again? What if I do try again, but it doesn't work? What if I try again and it kind of worked, but it didn't? Do we try yet again? So you need all of those questions answered, kind of have a mental flow chart so you know where you're going.
I got one for you.
Okay.
Hello.
That's it? That's all you got me?
How it started, with an exclamation mark. I had to give it its pause.
Okay.
It wasn't like a comment, exclamation mark. Hello. I'm 35.
Okay.
With 1 embryo left.
Okay.
Having lap surgery in the next 2 months.
Okay.
Doc wants to do an ERA.
Oh.
Then a final FET. Would you do another retrieval before the FET?
Oh. Well, okay, there's 2 parts to that. So don't do the ERA because the ERA is useless unless there's a problem with your lining, like it's too thin or something. And then in terms of would I do another retrieval at 35, I would if you're planning on having more than 1 child, and if you can afford it. But if you can't afford it, then no. And if you're happy with just 1, but you're 100% sure you're happy with just 1, no, I wouldn't do another cycle. You could just try and see how things go. Good question.
I needed Viking.
Yeah, that was a good one. Maybe
Oh yeah, I saw it.
multiple processing.
Do you recommend male with lower count to still have intercourse right at time of overdrill for a IUI? It's our 4th time trying.
Yeah, you still want to try every day or every other day, even if he has a low count. The sperm can live inside a woman for days. So the more you pile in there, the better. And actually, the more frequently you ejaculate, the higher your sperm count gets within reason. So I wouldn't necessarily do it every day, but every other day is reasonable. So on the day of overdrill would be fine.
What is your progesterone protocol after FET? If you recommend vaginally, orally, PIO, all of the above, what do you recommend mostly at your clinic?
Well, we universally recommend both PIO and vaginal. You should never take progesterone orally because it has 10% of the bioabsorption. So it's useless when you take it orally. It's very good at making you sleepy and tired and exhausted, but that's all it will do. So you should be using vaginal and oil. We know that from multiple studies, including one we presented on the show 3 months ago, maybe 4 months ago, where it was very clear that the progesterone and oil with the vaginal had a better outcome than either of them alone. So oil is best, vaginal is second best, but the out of those 2, but combining them together is the best. So we always use both. We stop the oil at 12 weeks. We continue half the dose of the vaginal till 36 weeks because most of our IVF patients are a little bit higher risk and we don't want them going into preterm labor.
There's a question that came relatively recently,
Okay.
but I enjoy the comment.
Oh, okay. Fine.
So there's a big bias here.
It's a big bias.
It's a
All
big
right.
bias.
Somebody caught Tarek's attention.
That's
Here
right.
we go.
Hello, Dr. V.
Hello.
Thank you. You are seriously so awesome to follow, watch, listen to.
Oh, thank you.
And T is a fun addition to the live shows. Tuesday nights are no longer a bore.
Oh, awesome.
You can take
Awesome.
that to the bank, I
There you go. We could take the, well, we can't actually
But
take
yeah,
any of
but-
this. We're not making any
But there's
content.
something to be said about
There
that.
you go. That's awesome. Thank you for that lovely comment. We appreciate that feedback. Thank you. It means a lot to me. Bring friends.
Me
We want
too,
more
me too.
subscribers.
Brings a lot to me.
And Tarek says it means a lot to him as well. Yeah. But he's still not coming on screen.
That's right. Everybody's got their realm, chances of success on a first FET of a normal embryo.
Depends on your protocol, depends on you. With us, about 70% on average, 75. So yeah, I mean, it depends on who you are, how old you are, how good the quality of the embryo is. Success questions are good questions, but I need like an hour-long talk with you to give you a reasonable number, right? It's not something where you just say, first embryo, it's PGT normal. So if you watch the show regularly, you'll realize a PGT normal embryo from a 40-year-old compared to a PGT normal embryo from a 35-year-old, the 40-year-old has a 40% lower chance of a live birth. So you can't just say, I have one normal embryo, what are my chances? Because I need to know your age, I need to know your BMI, I need to know your partner's sperm quality. What was his DNA fragmentation like? What is the grade of the embryo? What's your center like? What protocol are they using for you? So there's like a lot that goes into it.
Can metformin also help FET success with PCOS?
Oh God, yeah, you should always be on metformin if you have PCOS. Yep. Go if you have PCOS and you're in the non-thin PCOS category. I always choose that description carefully. Then you should just be on metformin permanently. Like if you have insulin resistance, stay on it because there's a study in the New England Journal many years ago that demonstrated that people that stayed on metformin that were at risk for diabetes delayed the onset of their diabetes by a year or two. Delaying diabetes onset is important. I mean, you do not want to end up with diabetes. So the longer you can hold off, the better off you are. And I just got something in my eye. Go for it.
I'll answer the next one.
Yeah, you can answer.
When do you tell patients to stop trying through IVF with their own eggs?
Wow, it depends. So it depends on the center that you're working with. It depends on your egg quality. It depends on how many you're capable of producing, what kind of embryos we get from you. So if you can continue to make me genetically normal embryos at a reasonable number, I'm willing to continue trying for usually 3, maximum 4 cycles. That's kind of twisting my arm a bit. Maybe a total of, I don't know, less than 5 times in my career have I done it more than 4 times on one patient. If you are producing good embryos and you're resulting in a miscarriage or a chemical pregnancy, then I'm probably willing to continue one extra time because that one like almost made it, right? If you are making not great embryos, you get an egg, it won't even become a blastocyst. We try again, you get the same outcome. I mean, even after 2 tries, I'm going to say, look, we're only getting 1 or 2 eggs. Neither of these are even reaching day 5. Do you really want to invest more into this? So we're quite cautious about it. I get a lot of American patients. A lot of our American patients have insurance. Many of them have done, IVF treatments 5 times, 6 times, 7 times, 10 times. I mean, we have loads of patients that have done it over and over and over and over and over again. So does that make sense to me? No, I mean, that's a money grab in my opinion. So I don't work like that. It's even worse in Australia where apparently there are some fertility specialists down there that say you should not even think of donor eggs until you've done IVF 16, that's 16 times. I mean, that's absurd to be poking a needle into someone 16 times. So, it's got to be reasonable, but it is center dependent. If your center has a 30% success rate like they do in most of the Middle East, well, then you might need to try it 5 or 6 times and the framework changes. If you're like us and you have a crazy high success rate, you know, doing 2 or 3 tries, that might be enough to convince you need to try somebody else now.
Hi, Dr. Victory.
Hello.
I just want to say thank you.
Aw.
Just got back my beta back from Life Labs, and it's 152 after our FET on May 14. We are beyond thankful and can't wait to hear from the clinic in the AM.
You cheater. You went too early. Congratulations. Super happy for you. That's amazing. So yeah, congrats. We're very excited for you. That's amazing. It's such a good feeling, eh?
Absolutely.
It is. It's really cool. I mean, getting to be part of this for all of you guys is just, it's very inspiring, and it's so rewarding to see that we get so much, you know, out of it for patients, and that we get something out of it too, which is the sheer joy of knowing we've helped build a family. And it's so important. And I got to take a moment to say my heart goes out to those families in Texas. I don't know if you heard about that, but some lunatic walked in and shot 14 children dead. So my heart goes out to those families. That's a travesty, and our prayers and our thoughts are with you.
My hormone AMH is 0.07. Can I get pregnant?
Can you? Yes. Will you with your own eggs? It would be extraordinarily difficult. I never say never, but it would be extraordinarily difficult. Yeah, I mean, you're essentially menopausal, so that's not going to be easy. That's going to be a huge challenge. It can happen, but you're talking very, very, very low chances, like 1 in 1,000 kind of thing. Sorry.
Can you explain how you use letrozole FET protocol?
So we use it like normal, day 3 to day 7. And then we follow your lining. And if your lining's not getting thick enough, we add in a smidgen of estrase, like 1 milligram of estrase, vaginal. And then you just wait for the lining to thicken, and it always thickens enough. You got to make sure you're not growing and releasing an egg. And as long as you don't grow and release an egg, you're good to go.
Hi, Dr. V and T.
And T.
You guys rock.
Yeah.
Love rocking.
I love rocking too.
If elevated immune cells are found,
Yeah.
what is the typical protocol? Is IVF needed, or can you do something else to increase chances of pregnancy? Sorry if I already asked.
No, you don't need IVF. And I don't think we already asked that one yet. So you don't need to do IVF necessarily. We have patients that are doing insemination or even trying naturally, and they'll use any of the various things. So it does depend on what's wrong for me to be able to tailor an immune protocol for you. But depending on what the problem is, there are different immune therapies that will work. We mentioned a bunch of them earlier on the show: steroids, intralipids, to some extent heparin because it's a good anti-inflammatory, tacrolimus, sirolimus, Plaquenil, Viagra, subcutaneous IG, IVIG. There are a whole host of things, LIT therapy, LIT, leukocyte immune therapy. So, or immunization therapy, I should say. So there are a ton of different protocols. There are a ton of different things that can be done. It just depends on what's wrong and how far you want to go on fixing it.
Congratulations, Tommy. Just a comment. Yeah. I have an appointment with you in July.
Okay.
That's it. They're just super excited.
Oh, well, thank you. I'm super excited to chat with you. Sorry you have to wait. It's busy. Very, very, very busy.
I was thinking of putting my scrubs on and just...
You want to put on some scrubs and start answering? You know what? You've been around long enough. You probably could answer stuff.
Advice for low morphology.
Vitamins, cold therapy, frequent ejaculation, no smoking, no drinking, no drug use, healthy diet, daily exercise, keep the testicles cold. Stay away from hot tubs, jacuzzis, saunas.
A positive at-home pregnancy test 7 days after frozen.
If they didn't, God, I love you guys. If they didn't give you HCG, then you're positive, unless it's LH from a recent trigger. See if the line's getting darker. If it's getting darker, you have to be positive. If it's getting lighter, then that's a different story. Yeah, but just wait. I know it's tough. No one's come up with the perfect strategy for the 2-week wait, but it's totally doable.
I have a crystal ball.
Or you could pay Tarek some unnamed sum and he will check his crystal ball.
Yeah. It's pretty good.
Kind of like 50-50?
Kind of like 50-50. You got it. It's kind of like 50-50.
Great accuracy. Okay.
I'm 31.
Yeah.
5 years old. My AMH is 0.07. How many percent for...
She asked us that.
Yeah.
Yeah. Low percentage. It's probably less than 1 in 1,000. It's going to be very, very difficult. The studies say that at that level, even with IVF, the chances are 0. I don't believe that, but it's going to be very, very low.
We need to see Tarek. It's a good day.
It's funny you said that because I was about 20 feet up on a ladder yesterday, like literally 20 feet. And my wife goes, "You're afraid of heights." I'm like, "I'm not afraid of heights. Why are you saying that?" So the rest of the day, every 5 seconds when I was walking around her, I go, "Ah!" She go, "What?" And I go, "I'm afraid of heights," even though it wasn't on the ladder anymore.
Yeah. Lab surgery versus Lupron depot. How do you decide which one to pursue multiple fill transfer at the age of 39?
That's a good question. I mean, I am a surgeon at heart, so I like to fix problems, and there's no better way than the surgery. Plus, I'm by nature the kind of person that wants to answer questions for patients. So I don't want you wondering if you have endo. I want you to know if you have endo so you know what options and choices you have. So for me, I like surgery. I am happy to admit I'm in a minority of physicians because the vast majority of fertility specialists no longer do surgery because it takes up a lot of their time. It's certainly not financially viable because we make way more in the office than we do in the OR. And it delays people getting to therapy. So most centers have abandoned, most physicians, I should say, have abandoned their surgical practice in favor of just doing more and more IVF. I don't believe in that because I only want to do what's best for the patients, and the money and all the other stuff is not important to me. So for me, I want to make sure that I'm doing the right thing for you every single time. And to me, that means doing surgery because I get answers for you. I get to treat you at the same time and improve your chances. And then it also lets me give you a more informed discussion so that you can then decide what's my next best step. If you have brutal endo and it's a mess in there, you might want a surrogate. If your endo is not bad at all, we may need to consider looking at immune testing. So just putting you on Lupron doesn't necessarily solve the problem if I don't know if you have endo or not. And so because of that, I'm kind of a big believer in the surgical approach. 1 minute. Tarek's terminal question. TTQ.
I think, really, eh?
Is it a busy night?
That's okay. It's good. That's good. You could end them all. You can end them all.
Oh, okay. All right. Fire.
We did the lap surgery. Okay. If you have endometriosis, can you get pregnant with using embryos?
Yeah. It requires special protocols, but yes, you can get pregnant. Yeah. But you need an endo protocol, which most centers don't know how to do properly.
Should I continue my letrozole cycle? I have 2 more, and I am taking double dose 5 milligrams day 5 for 5 days, and continue to try using my surgery or see a fertility specialist for IVF.
I'm not sure I understand the question. You're certainly welcome to try letrozole a couple more times. It depends on your age. It depends on many factors, how long you've been trying, but there's no harm in seeing a fertility specialist. I'm not sure how you got letrozole without seeing a fertility specialist, but in any event, if you've only tried once or twice, it's totally reasonable to try a bit more.
Thank you for always being so understanding. A lot not understand the challenges and emotions a couple struggling with infertility go through. Hearts.
Oh, well, thank you. When we built our VRC program, we spent a lot of time focusing on the emotional component. I have to say I can't take credit for that. It was actually one of my patients that brought it to our attention on how to make that better, and I listened to her. And you probably know who you are, very curly hair and lots of babies. We listened to her, and we built our program around her suggestions. So I love you dearly, you know who you are. We created a program that really reflects a comprehensive kind of holistic approach to things, including mental health. So we have a free online program that lots of our patients love to use. It's very sophisticated, it's very beneficial. We have psychologists, we have a social worker, we have a naturopath, we have a family doc that can do counseling. And we're just onboarding a new service called BRIA, which is for psychiatry and additional resources and help. They're out of Toronto. We just met with them last week, and they're going to be coming on board as well. So there's tons and tons of resources to help you. And that's important because it's not enough to just say to people, here, take this medication and let's bang in that sperm or the IVF and you're going to be fine. Infertility is traumatic, and to not recognize that trauma is negligent on the part of the physician. So we have to acknowledge it. We need to address it in order to take care of all of you, rather than just, here's the sperm and here are the eggs and so on and so forth. Yeah. Done? All right. Well, we ended off on a good note there, I guess. My sincere condolences to those families in Utah again. Thank you all for joining us. We love you. We will be back again next week on Tuesday for another show, and hopefully there will be a good topic at that point. And then we will answer some more questions. So make sure you click that like button and the subscribe button, and join us again next week.